Hello friends, welcome to my channel Healthy World. Today I will talk about diabetes mellitus. Diabetes refers to a group of metabolic disorders that results in hyperglycemia. This is because in diabetes excess sugar is found in blood as well as the urine. Depending upon the etiology of the diabetes mellitus, factors contributing to hyperglycemia include reduced insulin secretion, decreased glucose utilization, and increased glucose production. The pancreas secretes insulin into the bloodstream. The insulin circulates, enabling sugar to enter your cells. Insulin lowers the amount of sugar in bloodstream. As your blood sugar level drops, so does the secretion of insulin from pancreas. Etiologic classification. Type 1 diabetes mellitus develops as a result of autoimmunity against insulin-producing beta cells, resulting in complete or near total insulin deficiency. Type 2 diabetes mellitus, group of disorders ranging from variable degrees of insulin resistance, impaired insulin secretion, and increased hepatic production. Specific type of diabetes mellitus, genetic defects of beta cell, genetic defects in insulin action, disease of exocrine pancreas, endocrinopathies, drug-induced, and infections. Gestational diabetes mellitus, develops during pregnancy. Type 1 diabetes mellitus. 5 to 10% of diabetes mellitus, previously termed as insulin-dependent diabetes mellitus or juvenile-onset diabetes mellitus, results from a cellular-mediated autoimmune destruction of beta cells of the pancreas, commonly occurs in childhood and adolescence, but can occur at any age. It is related to multiple genetic and environmental factors that are poorly defined. These patients are prone to other autoimmune disorders such as Graves' disease, Hashimoto's thyroiditis, myasthenia gravis. Pathophysiology. It occurs due to autoimmune destruction. Pathologically, the pancreatic islet are infiltrated with lymphocytes. After all beta cells are destroyed, the inflammatory process weakens and the islets become atrophic. It leads to a deficiency of insulin secretion. Type 2 diabetes mellitus. Cause is a combination of resistance to insulin action and an inadequate compensatory insulin secretory response. It accounts for 90 to 95% of diabetes mellitus. Previously termed as non-insulin dependent diabetes mellitus or adult-onset diabetes mellitus. Individuals have insulin resistance and usually have relative insulin deficiency. Most people are obese. Insulin levels may appear normal or elevated. The risk increases with age, obesity, and physical inactivity. Pathophysiology of type 2 diabetes mellitus. In the early stages, glucose tolerance remains near normal. Despite insulin resistance, the pancreas beta cells compensate by increasing insulin output. As insulin resistance and compensatory hyperinsulinemia progress, the pancreatic islets are unable to sustain the hyperinsulinemia state. Impaired glucose tolerance then develops, characterized by elevation in blood glucose. Other specific types of diabetes mellitus. Genetic defects of beta cells. Early onset of hyperglycemia less than 25 years. Called as maturity onset diabetes of young. Characterized by impaired insulin secretion with minimal or no defects in insulin action. Autosomal dominant inheritance. Genetic defects in insulin action. This is genetic defects in insulin receptor. Disease of exocrine pancreas. Any process that injures the pancreas can cause diabetes. Example: pancreatitis, trauma, infection, pancreatectomy, carcinoma, etc. Endocrinopathies. Several hormones, growth hormone, cortisol, glucagon, epinephrine, antagonize insulin action. Excess amount of these hormones can cause diabetes. Drug-induced. Drugs like glucocorticoids, thyroid hormone, beta-adrenergic agonists, epinephrine, and antipsychotics. Infections caused by Coxsackie virus B, cytomegalovirus, or congenital rubella. Gestational diabetes mellitus. Glucose intolerance developing during the second or third trimester of pregnancy is termed as gestational diabetes mellitus. Insulin resistance is related to the metabolic changes of pregnancy, during which the increased insulin demands may lead to diabetes. American Diabetes Association recommends that diabetes diagnosed within first trimester be classified as pre-existing pregestational diabetes. Most women with gestational diabetes mellitus revert to normal glucose tolerance postpartum but have a substantial risk of developing diabetes mellitus in next 10 to 20 years. Sign and symptoms of diabetes mellitus: polydipsia, increased thirst, polyuria, frequent urination, polyphagia, extreme hunger, unexplained weight loss, fatigue, blurred vision, slow healing sores, frequent infections. Diagnosis: glycosylated hemoglobin, diagnosed as greater than or equal to 6.5%. It reflects average blood glucose levels over a 2 to 3 months period of time. Fasting plasma glucose, diagnosed greater than or equal to 126 mg per dl. Fasting is defined as no calorie intake for 8 hours. Postprandial plasma glucose, diagnosed greater than or equal to 200 mg per dl. Taken after 2 hours of calorie intake. As per World Health Organization, glucose load should be equivalent to 75 grams anhydrous glucose dissolved in water. Random plasma glucose, diagnosed as greater than or equal to 200 mg per dl. Screening. The American Diabetes Association recommends screening of all individuals aged greater than 45 years, every 3 years. Screen at an earlier age if they have BMI greater than 25 kg per meter square and having any risk factors. Risk factors: family history of diabetes, overweight, physical inactivity, glycosylated hemoglobin previously identified of 5.7 to 6.4%, having history of gestational diabetes mellitus, hypertension, polycystic ovarian syndrome, and having history of cardiovascular disease. Approach to the patient. Once the diagnosis is made, attention should be directed to symptoms related to diabetes mellitus and classifying the type of diabetes mellitus. Type 1 diabetes mellitus. Onset of disease prior to age 30 years, lean body habitus, requirement of insulin as initial therapy, and having association with other autoimmune disorders like autoimmune thyroid disease. Type 2 diabetes mellitus. Onset after 30 years, are usually obese, may not require insulin, and may be associated with insulin resistance, hypertension, cardiovascular or polycystic ovarian syndrome. Maturity onset diabetes of young. It is monogenic form of diabetes mellitus, should be considered in early onset diabetes mellitus. This is autosomal dominant inheritance, genetic testing should be considered. Nutritional recommendations in diabetes mellitus. Vegetables, fruits, whole grains, legumes, low-fat dairy products, food higher in fiber and lower glycemic content should be eaten. Foods to avoid: saturated fats, trans fat, cholesterol, and sodium. Physical activity. Exercise has multiple positive benefits including cardiovascular risk reduction, reduced blood pressure, maintenance of muscle mass, reduction in body fat, and weight loss. Exercise is also useful for lowering plasma glucose and increasing insulin sensitivity. The American Diabetes Association recommends 150 minutes per week of moderate aerobic physical activity with no gaps longer than 2 days. Resistance exercise, flexibility, and balance training is advised. Pharmacological treatment. According to American Diabetes Association, the goal is to achieve glycosylated hemoglobin as normal as possible without significant hypoglycemia. The target is to achieve less than 7%. type 1 diabetes mellitus. Main types of insulin preparations are: rapid-acting, insulin starts to work within 15 minutes and its effects last for 3 to 4 hours. Short-acting, insulin starts to work within 30 minutes and last for 6 to 8 hours. Intermediate-acting, insulin starts to work within 1 to 2 hours and lasts for 12 to 18 hours. Long-acting, insulin starts to work a few hours after injection and lasts 24 hours or longer. Insulin regimen. In all regimens, long-acting insulin, NPH, glargine, or DMKINEMASTER, supply basal insulin, whereas regular insulin aspart, or Lispro provide prandial insulin. Short-acting insulin should be injected less than 10 minutes before the meal, and regular insulin 30 to 45 minutes prior to meal. In general, individuals with type 1 diabetes mellitus require 0.4 to 1 unit per kg per day of insulin divided into multiple doses, with approx 50% of the insulin given as basal insulin. One commonly used regimen consisted of twice-daily injection of NPH mixed with a short-acting insulin before the morning and evening meals. Such regimens usually prescribe 2/3 of the total daily insulin dose in the morning, with about 2/3 given as long-acting insulin and 1/3 as short-acting insulin, and 1/3 before the evening meal, with approximately half given as long-acting insulin and half as short-acting. Type 2 diabetes mellitus. Glucose-lowering agents used are biguanides, sulfonylureas, dipeptidylpeptidase 4 inhibitors, glucosase inhibitors, thiazolidinediones, and sodium glucose cotransporter 2 inhibitors. Insulin therapy for type 2 diabetes mellitus. Insulin should be considered as part of the initial therapy in type 2 diabetes mellitus, particularly in lean individuals or those with severe weight loss, underlying renal or hepatic disease, or who are hospitalized, or actually ill. Because endogenous insulin secretion continues and is capable of providing some coverage of mealtime caloric intake, insulin is usually initiated in a single dose of long-acting insulin, NPH, glargine, or DMKINEMASTER, given in the evening or just before the bedtime. Long-acting insulin may be used in combination with oral glucose-lowering agents. Initially, basal insulin may be sufficient, but often prandial insulin coverage with multiple insulin injections is needed as diabetes progress. Choice of initial agents. Mild hyperglycemia, fasting plasma glucose 126 to 199 mg per dl, often respond well to single oral glucose-lowering agent. Those with moderate hyperglycemia, fasting plasma glucose 200 to 250 mg per dl, will require more than one oral agent or insulin. Patients with more severe hyperglycemia, fasting plasma glucose greater than 250 mg per dl, may respond but unlikely to achieve normoglycemia with oral therapy. Insulin can be used as initial therapy in individuals with severe hyperglycemia, fasting plasma glucose 250 to 300 mg per dl, or in those who are symptomatic from the hyperglycemia. Acute complications. Diabetic ketoacidosis and hyperglycemic hyperosmolar state are acute disorders related to hyperglycemia, plasma glucose greater than 250 mg/dl, chronic complications. Microvascular. Retinopathy, neuropathy, and nephropathy. Macrovascular. Coronary heart disease, peripheral arterial disease, and cerebrovascular disease. Other. Gastrointestinal, genitourinary, dermatologic, infections, and cataract. I hope you got all the informations about diabetes mellitus. Thank you.